Overactive bladder, a symptom complex, sudden desire which is unable to defer, which cannot be deferred, urinary urgency is overactive bladder. It's a clinical diagnosis. It is in two forms, dry and wet. Wet is because of leakage. So if because of sudden compelling desire which cannot be deferred, patient leak, then that is the wet OAB. And another one is a dry, where the patient does not leak, only the patient is having the urgency sensation, which is not accompanied with leakage. Okay. Now it is a symptom complex. There is an increase of frequency, there is nocturia and incontinence, that is leakage. And in the definition, what is overactive bladder included is these symptoms are present in absence of urinary tract infection. There is no urinary tract infection, then it is called an OAB, and other obvious pathologies are ruled out. Okay, then it is termed as overactive bladder, most important. Okay. So in a male, female, both in female, wet OAB is more common. 12 to 20% of the adult population have overactive bladder. Now there are various clinical comorbidities where the prevalence of OAB is increased, like diabetes mellitus, metabolic syndrome, heart disease, dyslipidemia, alcohol, smoking, neurological issues, and previous pelvic surgery. Yes, a case of post hysterectomy has more chances, more increase of overactive bladder, more chances of urgency. Then fibroid, anterior wall fibroid in the near the lower uterine segment impinging the bladder, the patient may have overactive bladder, the urgency to go repeatedly to the urine. Then impaired mobility, frail elderly population, impaired mobility because of they are not able to access when they have urgency, they are not able to mobile easily. They have the overactive bladder, they call leak, or they have increased urge to go. Okay, so these are the prevalence conditions comorbid where the prevalence is increased. Parity, more the parity, more the chances of stress urinary incontinence. Okay, as the age increases of the patient, there are more the chances of overactive bladder. This is one of the general phenomena. A young female can have urgency as a predominant symptom, and a 60-year-old female may have only pure SUI as one of the symptoms. But usually, the more the parity, the more the chances of prevalence of SUI. SUI usually in the early ages, and as the age increases, the prevalence, the incidence of overactive bladder increases. Now, what is the pathophysiology of overactive bladder? It's myogenic related to detrusor muscles. It can be neurogenic, or it can be both myogenic and the neurogenic component helps in the causes the overactive bladder. Okay. So, neurogenic, specifically what I want to specify here is one is the sensory nervous system and the central nervous system. What happens is that excess sensory information is compelled from bladder to the brain. Excess sensory information is transferred from bladder to the brain, and it gives a repeated sensation of urgency even if the bladder is empty, even if there is no need to desire, or even there is no sufficient volume. It's like first desire is usually 150 to 200. So in that lower volumes also the bladder brain gets the sensation for the urge to pass the urine in the overactive bladder. Have you ever wondered why anticholinergics does not improve the symptom of a patient with overactive bladder? Anyways, not all overactive bladder require anticholinergic as a treatment. In other words, even very few cases of overactive bladder require the anticholinergic as a treatment of this. But have you wondered why anticholinergic does not improve the overactive bladder symptoms? So here are the list, or here are the differential diagnosis of the causes why the anticholinergic will not work in the cases of overactive bladder. So you will see, their very first thing I would like to say is polyuria. The patient will produce more urine, more frequency. There is nocturia also, and the patient is having urgency, the desire, because it's so much of the urine because repeatedly, and there again the fear of leakage is there. So that is what. Nocturnal polyuria, daytime it's okay. Many patient comes only they have the nocturia. So this by bladder diary, you can know the patient is having nocturnal polyuria, and by that you can know that because of that patient is having only nocturia. The patient usually don't have the increased frequency or urgency anything in the daytime, but in night time there is nocturia because it may be a case of nocturnal polyuria. Bacterial cystitis. Inflammation of the bladder, irritation to the bladder, it comes again as I said in the neurogenic component sensory, increased sensation is gone to the brain and there is increased sensation of urgency. SUI, yes, stress urinary incontinence. So you may have heard the term of CADO, cough associated detrusor overactivity. That leads to detrusor over, that is the overactive bladder. Then with this bladder cancer, yes, it may present as urgency. Bladder stones, yes. Chronic urinary retention. When the urine is chronically retained in a patient, the patient have, because it's not getting emptying well, so again the patient have repeated urgency to go to washroom. Okay, that is one. Bladder outlet obstruction, prolapse. Prolapse patient comes with increase in frequency, hesitancy, urgency. Because there is obstruction, there is outlet obstruction that leads to incomplete bladdering and that the patient has a repeated sensation to go. Atrophic vagina, menopausal, postmenopausal female, they have atrophic vagina and that may lead to overactive bladder, urgency to the patient. Bladder pain syndrome, one of the very common topic. Bladder pain syndrome also the patient have the repeated persistent urgency symptoms are there in that. Patient may be on some drugs like antidepressant, antipsychotic, calcium channel agonist, alpha adrenergic blockade, diuretics, which may lead to the patient to the increased volume, frequency, nocturia, and even patients may have urgency. Again, urgency, a normal urgency, patient may have repeated urgency. Overactive bladder, urgency, overactive bladder is sudden, compelling or not able to defer the urination, that is overactive bladder. And then comes the detrusor overactivity. Detrusor overactivity is a finding on urodynamic study. All OAB patient does not have detrusor overactivity. Very few patient of detrusor OAB have detrusor overactivity, and all patients who have detrusor overactive not necessarily they manifest. So urodynamic is not one thing you do in routinely for urgency patient also, and it's not even a diagnostic modality where you define. So OAB overactive bladder is a clinical diagnosis. Okay, urgency a patient can have normal persistent urgency. Overactive bladder is sudden or compelling desire which is not able to defer, that is overactive bladder. And detrusor overactive is one of the urodynamic study finding of our overactive. Not all patients of overactive bladder will have detrusor overactivity. Okay. Now this happens. Now on examination, we have seen a previous one video on urogynecological examination in detail. We have seen the urogynecological examination, SUI, prolapse. So I just want to add here one point related to overactive bladder in examination. What we normally do in urogynecology examination, we ask patient to comfortably bladder full. We demonstrate SUI. We ask her to empty the bladder, and then again we examine. Now, when you again examine, especially for a case of overactive bladder, you suspect the patient is having persistent urgency, you specifically try to look for bladder. You palpate the bladder. Palpation of bladder is important in overactive bladder. Now, what happens here is in chronic urinary retention, you may the patient has just empty, but still you are feeling the bladder full. It may be overflow incontinence. That is now the terminology has changed to chronic urinary retention. Okay, it may be happen. There may be tenderness, bladder tenderness. It is usually seen in case of central bladder pain syndrome. So these some findings you can pick up on examination while we ask to see the patient. Okay, detailed examination you can see the one of the video I have recorded, pelvic organ prolapse examination. In that detail you will see how to examine a patient. So after examination, investigation specific to overactive bladder. Routine investigation advice, that is okay. Specific to urine routine microscopy. That is the very first investigation whenever you suspect a patient of the repeated urgency, overactive bladder. In the routine microscopy, what you see? Three important points. Very first, you see the infection, any urinary tract infection, any pus cell, RBCs. You see microscopic hematuria if the patient is having. Then you see for glycosuria. This is the three important things you see in the urine routine microscopy. Okay. Then comes investigation is the questionnaire. Yes, any urogynecological case, questionnaire is very important. It just not only give you idea of the quality of the life, you even get to know that which symptom is the patient was. She's bothered with frequency, she's bothered with nocturia, she's bothered with leakage. I mean, even it helps you in monitoring, because it's not like one day treatment. When the patient comes, you write the drug or you give the conservative management and then follow. You should know what were the previous symptoms, what which has improved. So questionnaires play a very important role in urogynecological history and evaluation. Okay. For overactive bladder, there are many questionnaire you can use. Commonly, urinary distress inventory questionnaire UDI 6. That is one of the questionnaire you can use it. Okay. Then comes the bladder diary. Obviously, it's not mandatory, even it's not recommended for each and every urgency patient. But yes, if it's any difficult cases, because the cases which you get in books, it is not in the clinical practice. In clinical practice, you don't get the easy or normal cases. So if there is any complicated cases, any warding dysfunction, or the history and examination and everything is not correlating, then definitely you want to have an idea of bladder diary. One thing more about bladder diary, it's just not only diagnostic, it definitely gives you valuable information. It's a very important tool. But it's not only diagnostic, it's even therapeutic. Yes, bladder diary itself is a therapeutic also in cases of overactive bladder. So definitely you want the patient to maintain it. But in clinical practice, at least in the our setup, patient who don't have, the patient will not, is not comfortable or doesn't make that, or it's difficult to make them understand what you can do whenever, but whenever you need or you require, yet it's must, or chronic cases or any complicated cases you want bladder diary, I would recommend you first advise the patient to make a frequency volume chart. Yes, that is also somewhat easier than the bladder diary, and it also gives you a lot of information. And if that, again, it should be also made for 3 days, but if not able, at least 1 or 2 days can be done. And it also give you a very valuable information, and will help you in the diagnosis and the management of the patient. And still after that you feel that no, it's not sufficient, you want a bladder diary, then once the patient has made frequency one day, it's easier understand, or patient will understand the importance of bladder diary, and the patient will get motivated to make. So I would recommend, whenever you feel like in cases of you need to make a patient a bladder diary, first let go through a frequency volume chart. You always advise the patient. Then comes an investigation imaging, not routinely required. Obviously, if you suspect any stone or cancer with other investigation, urine and patient profile history, and any risk factor, then. But for management, investigation is required. No, imaging is not mandatory to manage a overactive bladder or urgency patient. But one thing in the imaging, you have to be the post void residual volume. Yes, before you manage or you treat a patient of urgency, this post void residual volume is mandatory, or not actually mandatory, but yes, you should have it. It's better to have a post void residual urine flow before you start treating the urgency patient. So if any two investigation most important or should be done in case of treatment for overactive bladder is, one is the urine routine microscopy, and the second is the post void residual volume before you start, even for the monitoring. And there are many various benefits to do this. Your urine RMC you have to start before you manage a patient. You have to see it, and the post-void residual. Uroflowmetry not required routinely for an urgency patient, even for starting the investigation or even for the monitoring. Yes, but if it's overactive bladder associated voiding dysfunction or mixed urinary incontinence, where you're planning later on surgery for STI, so you can have a pre-baseline before you start anticholinergic. And many of them, before starting, many practitioners before starting any anticholinergic, they usually make up first uroflowmetry, and then they start the anticholinergic. But it's not like mandatory, but it do the better. Simple cases not needed. You can start a treatment without uroflowmetry. So this in short, if you want to remember investigation, again I repeat, urine routine microscopy and post-void residual. Please at least have this two investigation in hand before you start treating the patient of urgency on overactive bladder. So thank you for, if you like this video, please like, share and subscribe. Thank you.